Good afternoon, everyone. I am Zanfina Ademi. I am Associate Professor of Health Economics and Outcome Research at Monash University. Today, I'm going to be talking about modeling effective osteoarthritis care in Australia. Before I start my talk, I would like to acknowledge the people of Kulin Nations on whose land we are gathered today. I pay my respect to their elders past and present. The outline of my talk today is going to be why health economics, and I'm going to be taking you through a case study about the modeling of aggregated data to understand budget impact analysis of effective knee osteoarthritis care in Australia. I'm going to be talking about the final results, future direction, and summary. So why health economics? All health systems face financial constraints due to aging population, new technologies, and new diseases. So choices are unavoidable and have to be made regarding the use of available funds, and priorities have to be set. Therefore, the interest on health economic evaluation. We also have to remember that not all prevention strategies are effective, and there is a growing gap between what medicine can do and what is economically feasible to do. Remember, there is often more than one way of doing something in healthcare. For example, there are two different ways that can be used to manage osteoarthritis via physiotherapy or surgery. So we have to choose one of these options, either pick more effective strategy or pick less costly one. Economic evaluation used to identify, measure, and value both costs and outcomes of healthcare interventions. In generic terms, is the study that compares both benefits and costs of two or more interventions. There are a number of methods that we use in economic evaluation, such as cost-benefit, cost effectiveness, cost utility, and cost minimization analysis. But the most common used are cost effectiveness and cost utility analysis. These two methods differ between each other just by the way how we capture the outcomes. In cost effectiveness analysis, we capture outcome in a single unit of measure, such as events prevented or years of life saved, whereas in cost utility analysis, outcomes of alternative interventions are captured using utility values that we generate via quality of life measures. In a wider sense, economics capture also quality of life, utility studies, which fits under the umbrella of outcome research. Also, you've heard about cost of illness studies, which we capture burden of disease via studying the prevalence and incidence, and budget impact analysis. So today my talk is going to be about budget impact analysis. So what are the budget impact analysis? They're usually performed alongside health economic evaluations. But the only difference is that they're customized to a specific context and provide information about the total investment needed. So we assess affordability of adopting new intervention. And when we usually do budget impact analysis, we do it from a healthcare perspective. So my budget impact analysis case study today is going to be about potential healthcare savings from a total knee replacement avoidance related to a national implementation of a non-surgical management program for knee osteoarthritis in Australia. This is a published work, and I just want to acknowledge the GLAD Australia team that work in this paper jointly with me. So what is the GLAD program? It's a 6-week non-surgical management program for knee osteoarthritis rolled out across Denmark. Similar national programs have been implemented as well in other Nordic countries, such as Norway and Sweden. GLAD is also being implemented in Canada, in China, New Zealand, and Australia. To date, in Australia, over 800 physiotherapists have been trained with the GLAD program. And the GLAD program is offered in more than 250 clinics nationwide. Over 3,000 participants have registered for this GLAD program. So what did GLAD program showed in a randomized clinical trial in Denmark? A 12-week program national non-surgical management program was compared to total knee replacement surgery plus 12-week non-surgical management. People who were eligible in this randomized clinical trial were those with moderate to severe knee osteoarthritis. 12 weeks program was followed up for 2 years. So the results of 1 year were that 74% of people avoided total knee replacement if they had a non-surgical management, and by year 2, almost 68% of them avoided total knee replacement. So why we are interested in GLAD program? It's because the usual care in Australia is largely represented by only total knee replacement surgeries. So currently there are around 50,000 knee surgeries, total knee replacement surgery that takes place in Australia per year. And many patients have surgery without having even received an appropriate non-surgical first-line treatment management. So for us, it was interesting to look what could we save if the program was rolled out at national level, and we would use the data from the randomized clinical trial. We wanted to know what is the magnitude of the problem now and into the future. So we looked the population data from 2019 to 2020. We looked the prevalence data of knee OA in Australia, and we determined the population of interest that will undergo moderate to severe knee, will have moderate to severe knee OA in Australia. So you can see from this table that in 2019 there were already, almost 56,000 people who had moderate to severe knee OA, and by year 2029 almost 70,000. So usual care in Australia, as I mentioned, is undergoing total knee replacement. If we would implement non-surgical management program, we would estimate number of total knee replacement avoided if we would apply the evidence-based data that come from GLAD Denmark. So by 2019, if we would apply the non-surgical management program, we would avoid around 38,000 total knee replacement. And by 2029, we would avoid around almost 47,000 knee OA. In this study, we also looked, as I mentioned before, a cost of the surgery, but also the cost of non-surgical management. In a number of scenario analysis. So when we do a budget impact analysis, we do a number of scenario analysis to test uncertainty around our model. So we gave the sliding scale cost to the non-surgical management. So the cost of non-surgical management varied from $750 to $3,000 per program. And also we looked at what cost the program will be no longer cost effective. We also looked at the options if we would decrease the program effectiveness by 50%. And we also looked at what proportion program will be still cost saving if would implement it at the national level. So here are the scenario analysis. In a horizontal axis, you have total cost saving in 2019, and then a sliding scale of the program cost per recipient was from 3,000 to 750. Even if we increase the cost of the non-surgical management to 13,500, the non-surgical management, when was compared to total knee replacement in Australia, was still cost saving. Another scenario analysis, here you have a total knee replacement usual care in Australia, and here you have the non-surgical management. So the cost saving between these two were around 600 million. We also tested the effectiveness of the program. It has to be around only 8% effective to be still cost saving. So large savings will be generated if the non-surgical management, osteoarthritis management program via GLAD will be implemented in Australia. This is the first budget impact analysis to estimate healthcare savings. that could result from national implementation of comprehensive evidence-based management program for NEO-A in Australia. But there are some other limitations that we have to take in consideration. For example, we haven't taken in consideration long-term modeling of total knee replacement avoidances. We would like to sort of look at our surgery costs simply shifted to later years. And also we would like to look at a lifetime cost effectiveness analysis and the impact that non-surgical management would have on people's quality of life and also productivity. Thank you for listening, and I'm looking forward to our discussion on Sunday.